Good morning, everybody. Like she said, my name is K Schwalbe. I'm a fourth-year general surgery resident at Cleveland Clinic South Point Hospital, and I will be presenting endoscopic findings do not predict POP outcomes. We have no disclosures. So gastroparesis is characterized by a symptomatic delayed gastric emptying in the absence of a mechanical obstruction. The symptoms are assessed via the Gastroparesis Cardinal Symptom Index, or the GCSI. There are 9 symptoms in this, which are subdivided into 3 subscores, and the patients rank them on a 6-point Likert scale from 0 to 5, with 0 being no impact on their daily life, and 5 being very severe. The objective finding of delayed gastric emptying is assessed via gastric scintigraphy, or a gastric emptying study, GES, or also a wireless motility device such as a smart pill. This is how we perform our peroral pyloromyotomies, or POPs, or GPOMs. We use a standard gastroscope with a silicone cap and a TT knife to first make a submucosal bleb, and then a tunnel to the pylorus along the lesser curvature of the stomach. The pylorus is dissected free and then incised in its completion. On the left is an overview of that procedure, and on the right-hand side is what you actually see during the procedure. Our primary question was, do endoscopic findings predict POP outcomes? We had 2 hypotheses. One, that gastric bile would be a negative predictor for GCSI improvement, and the second one being that pylorospasm would be a positive predictor for GCSI improvement. We had 201 patients who underwent a POP procedure at our single facility with a single surgical endoscopist from January 1st of 2019 to June 30th of 2020. We prospectively collected endoscopic images on these patients, and then following IRB approval, performed a retrospective chart review. We also had a survey to involve our patients. They were informed about this study via mail and then email, and finally had a phone call to complete that survey. 53% of our patients completed the survey for a final number of 107. Our primary endpoint was clinical response as defined as a GCSI change in at least 1.0 from the preoperative to the survey time, and no need for further pyloric or gastric procedures for their gastroparesis. This primary endpoint was chosen in relation to other recent gastroparesis literature, stating that 1.0 is a significant change. Our secondary endpoint is our post-POP GES normalization as less than 10% gastric retention at the 4-hour time mark. These are some endoscopic findings. On the left-hand side at the top is gastric bile, and at the bottom is an absence of pylorospasm. It is our practice that if a patient has both gastric bile and no pylorospasm, a POP procedure is not performed. On the right-hand side of the screen are our 2 degrees of pylorospasm. On the top is the tight pylorus, where with applying pressure with the gastroscope to the pylorus, you can see the duodenal mucosa. On the bottom hand is the very tight pylorus, where that duodenal mucosa is not visualized. So for our results, our time to survey following the POP procedure averaged 697 days, so we are considering this a medium to long-term outcome. The range was 401 to 1,049 days, with some patients being followed up after 3 years following their POP procedure. This is the breakdown of the patients who responded to our survey. 71% of our patients have idiopathic gastroparesis. 19% are post-surgical, the most common precipitating surgery being a hiatal hernia repair of fundoplication, and the other surgeries are listed on the right-hand side of the screen. 10% of our population has diabetic gastroparesis. 27 of our patients underwent 31 previous procedures prior to this POP procedure, the most common of which was injection of the botulinum toxin to the pylorus. 1 patient did previously have a pyloroplasty in conjunction with another procedure. These are our demographics. As you can see, we divided our patients into 2 groups based on if they had clinical response or not, based on that GCSI score and the lack of further interventions. 42 patients achieved a clinical response for a rate of 39% at that 697-day time period. We found no significant difference in the demographics. We also looked at some drug uses that on our retrospective review that we know impact gastroparesis and can cause delayed gastric emptying. Once again, no significant differences. These are our endoscopic findings. 37 patients had no pylorospasm. 70 patients had some degree of pylorospasm. 33 patients had bile with or without gastritis, which has been implicated in decreasing the antroduodenal motility. And then it is our practice to ask our patients to do 3 days of a liquid diet prior to their POP procedure. 6 patients had food content, and all of them were in the no clinical response group. However, there were no significant differences. This is how we established our GCSI score change over time. We did have a postoperative, 69 patients completed a postoperative visit GCSI score, and the asterisks denote that there is a significant change in the score from the preoperative to the postoperative and from the preoperative to the survey time points. This is our secondary endpoint, the gastric emptying study results. 68 patients had a post-procedure gastric emptying study at an average of 145 days. 34 or 50% of those patients normalized at the 4-hour time mark. We did ask our patients subjective improvement questions. Have you noticed symptom improvement following your POP? 72 said yes, and 36 of those patients did not have clinical response as defined by the GCSI score. And then asked if they would do the POP again. 78 said yes, and 7 of the patients who had clinical response would not do the POP again. 23 patients went on to have 28 additional post-POP procedures, most commonly a J-tube, and 23 self-reported a complication at our survey time. This is our univariate analysis assessing if these variables impacted that GCSI score change of greater than or equal to 1.0. None of them were significant, including our endoscopic findings. We then went on to do a multivariate analysis of these 5 variables based on a p-value of less than 0.150. This is that multivariate result. None of them were significant. The one that was the closest is a preoperative GCSI score of greater than or equal to 2.6 that had previously in the literature been stated as a significant predictor. We have several limitations with our study, one being subjective endoscopic pyloric findings. We attempted to reduce this bias by having one investigator evaluate all of the images, and then low follow-up with the survey and the gastric emptying studies. So in conclusion, subjective endoscopic findings are not predictive of clinical response following a POP procedure. The GCSI model that we currently use to measure clinical success may not accurately capture the full clinical picture based on what we ask the patients for their symptom improvement. And the long-term durability of the POP procedure needs to be studied further to improve patient selection. Thank you.